Pharmacotherapy, please don't hesitate to use medicines if required. Please don't hesitate. If required, we have to give that for a short duration of time. Most of the patients complain that, what after stopping the medicine? It's a future. You can always talk about it later on. One thing. Second is, obesity is a dynamic process. Weight is a dynamic process. If it has gone down today, tomorrow it can come back. But now you know the way how to lose it. As simple as that. Never claim it's a permanent loss of fat. A lot of advertisement come that way. Never do that. We don't even let the HIV patient lose weight indefinitely. Madam, isn't it? We don't even let them lose weight indefinitely. And they are the pathological condition where people lose weight indefinitely and they die. And we don't want our patient to fall in that. After every 10% loss of body weight, there has to be a plateau. And if the plateau is not happening, then something is wrong. Because they are the people who will die of swine flu. They are the people who die of diarrhea, they cannot tolerate it. And here again comes hormesis. After losing 10% of weight, plateau has to be there. So tell your patient, if plateau is not coming, inform me, it is not good. That means you are having bad resistance system in your body. Okay? Then these medications are there, pancreatic lipase inhibitor, centrally acting medication. So, finally, I don't know, it's not coming very clearly in that. Growth hormone may play a role, but it is not side effect free. There may be some complications, and for growth hormone, we'll take a separate lecture tomorrow. Anti-epileptic medication which can prove for a short-term weight loss, 2 or 3 months duration. Is topiramate, bupropion, zonisamide, lorcaserin, and they all are working on the same pathway, agouti-related peptide and POMC pathway. So, is eating an addiction? It is recommended. It is now in, I think, आपकी book में भी आ गया, DSM class, whatever, I don't know. Food addiction is there. So food is an addiction. Forget about those burger, pizza and all. Even simple food eating is an addiction. I am in the conference, I have to eat. No matter what. So I keep on fighting with this addiction. I am in the conference, I have a food there, I will not eat. I may be wrong. But what I am saying is, yes, food is, any impulse which you cannot control is an addiction. So it should be treated that way too. So here comes the role of psychiatrist or counseling, whatever, behavioral modification. So sugar addiction, there was my article in one of the paper, but again, madam. So these are the medicines which are working. Phentermine on this pathway, topiramate. Now topiramate with the phentermine combination was approved by US FDA for short-term reduction of weight, but to be given only from the doctor's office. So various medicines. So the good part is once we know about a pathway, we can find medicines for it. So that's what is happening in obesity industry today. So let's see the prescription, final prescription. If a patient is coming in, and what should we do to make the patient lose weight? So this can be a broad thing. This is what I made. So my first target is to decrease the food intake. And I am talking only about the pharmacological aspect. Behavioral, talking, lecturing, everything is done. What patient has to do. Now let's say what we can do for the patient. So decrease appetite by using an appetite suppressant. Sibutramine is banned now. It is not no more approved by FDA, but we never know. It may come back again. That's what FDA does all the time. Bans a product, again brings it back like 5 minutes ago. We never know. Topiramate is already approved. Phentermine, zonisamide, lorcaserin, GLP-1 agonist, tea and coffee extracts. Lot of these herbal things are there in the market. Trying for a short duration depends on completely your discretion. Potential therapies can be drugs acting on leptin, adiponectin, ghrelin. So they will come. Now leptin injections are already available, but in the developed countries, that too in a higher institutions. Increase gut distension or release early satiety by again GLP-1 agonist, fibers, orlistat or herbs. Decrease absorption of fat by orlistat or satilistat or herbs. Now satilistat is one of the pancreatic lipase inhibitor which says that they will not have the side effect of orlistat. So I never use it. Because obesity cannot be dealt like this way. There has to be an end-abuse reaction to the patient. Orlistat is like a punishment. somebody is taking orlistat and eats a high calorie fat diet, is going to leak the real leaky gut syndrome, but externally. Will be leaking everything from the anal canal. So either he will stop the medicine or the food. So they call, doctor, what should we do? Decision is yours. You stop the medicine, you stop the food. What will happen if I stop the medicine? You will again gain weight. You will gain more and more of weight. Finally, stop the food, means this food, fatty food, and take orlistat till you don't pass more oil in your stomach. And that's how they get a, again an objective evidence of their dietary compliance. Substitution of fat, something like olestra. Olestra is an artificial fat which is being used in Lay's. You know that chips, Lay's chips, wafers, those packed wafers. So they use this olestra. But it is not good. It causes a lot of deficiencies. So it's very big size molecule. It is not absorbed by the intestine. Therefore, after eating that full Lay's packet and all, you start feeling bloated. But people have adapted to that also. Now they can eat so many. Decrease absorption of carbohydrate using acarabose or herbs. Again, I have never used acarabose myself just for the matter of weight management. Never used it. But yes, people do use it. Decrease absorption of bile. Again, I have never used polystyramine as such for the weight management, but potential is there if the studies can be conducted. Improve the insulin sensitization. Metformin, we spoke in the morning. Metformin is one of the longevity medicine already approved. AMPK. So, metformin, glitazone, GLP-1 agonist, glitazone, resveratrol, herb, resveratrol, SIRT1 receptor, sirtuin. Then increase the lipolysis finally. So what we did is, we decrease the food intake, then we try to decrease the fat. Patient is doing the exercise part. That patient has to do. This is what we are doing for the patient. Decrease the intake and then decrease the absorption, improving the metabolism, and then the lipolysis finally. So here is the potential role of growth hormone, testosterone, thyroid. Again, supervised, no blanket therapy, no one for all protocol. Catecholamine stimulation by ephedrine, again banned, not to be used. If using, at your discretion. Green tea extracts, coffee extracts and all. Lot of herbs are there which actually are similar to ephedrine. Right, we found about them, Dr. Vinay. Shift the fuel pathway from glucose to fat consumption, and here comes the role of HCG protocol and growth hormone. Maybe the combination can work wonders, probably. HCG with growth hormone. May or may not. It's no randomized controlled trial. It can be only observational things what we can do with the consent of the patient, not as a study part. Again, study has a lot of ethical value. Other target is preserve the protein. Now, when proteolysis is happening, you have to preserve it. Here comes the role of growth hormone, testo, protein supplements, and here comes the role of supplementation. Protein, high protein diet is not for the weight loss per se. High protein diet is to replenish the protein. Counteract the adaptive changes, whatever is happening in the body to restore that weight. So GH is going down, testo is going down, estrogen is going up or down, progesterone is changing, DHA is going down, thyroid TSH is going down, melatonin, protein. So you just have to take care of these. Increase the exercise endurance. First is by your own motivation system, by lecturing, by informing the patient, by following up the patient, plus protein supplements, growth hormone, testosterone, they all increase the exercise endurance for at least 1 year. After 1 year, the effect plateaus. After that, there is no extra advantage. Manage the deficiencies, definitely this has to be taken care of. Otherwise, patient was obese and then patient is normal weight with lot of deficiencies and patient is having more complications. That has to be managed together, and antioxidation supplementation with all these things. Can be various things from these all things can make a very good plan for. I'm not talking about weight loss, I'm talking about the management of an obese patient. Weight loss is only one parameter. So if a patient is coming to us with hypertension, bringing down BP is only one parameter. We have to take care of the retina, the kidney, the neuropathy component, the cardiac component. So similar way, obese patient has to be seen like this.